So good morning. Today we are going to see about dental cements. Introduction, definition, history, ideal properties, classification. We're going to see about silicate cements also. So introduction, in the last 20 years there has been an explosion of different types of dental cements that have become available to a practicing dentist. So dental cements in the recent years has become restricted to those materials which are employed to bond inlays, crowns, bridges, posts and facing in or on the tooth and to retain orthodontic bands and retainers. So these different applications make varying demands on manipulative properties, working in setting time and resistance to mechanical breakdown and dissolution. So many of these materials are supplied in powder liquid form and set by an acid-base reaction. But this is not universally true. As yet, there is no ideal dental cement, so each material must be used on its merits with knowledge of its limitations. So what is a cement? So according to Craig, it is a non-metallic material used for luting, permanent filling or temporary restorative purposes, which is made by mixing components into a plastic mass that sets or as an adherent sealer in attaching various dental restorations in or on the tooth. Okay, according to Anusavis, it is a substance that hardens to act as a base, liner, filling material or an adhesive to bind devices and processes to tooth structure and to each other. Next, history. In 1873, the silicate cement was introduced by Fletcher. In 1873, zinc oxide and clove oil by Chiasm. In 1879, zinc phosphate cement by Dr. Pierce. In 1930, the calcium hydroxide paste by Herman. In 1968, polycarboxylate cement by Dennis. In 1971, the glass ionomer cement by Wilson and Kent. So how should an ideal dental cement be? It should be strong and hard. It should be able to protect the pulp. It should be insoluble in saliva and liquids. It should be dimensionally stable. It should be adhesive. It should be non-porous. It should be biocompatible and non-irritant. Coefficient of thermal expansion should be there. Should not affect the thermal changes. Should be easy to manipulate. So classification based on ingredients and application, you have water-based cements, you have resin-based cements and you have oil-based cements. In water-based cements, you have GIC, zinc polyacrylate and zinc phosphate. In resin-based cements, you have composite and adhesive resins and compomers. In oil-based cements, you have zinc oxide eugenol and non-eugenol zinc oxide. Okay. In water-based cements, glass and resin modified glass ionomer, zinc polyacrylate and zinc phosphate. In resin bonded compomers, bonded conventional alloy-based restoration, composite and adhesive resins, it is bonding, which is in conventional alloy-based restoration for ceramic crowns, bridges, veneers, inlays and onlays, post and cores, and retention of provisional restorations and also orthodontic bands. Oil base, you have zinc oxide eugenol for high strength bases, provisional restoration, root canal sealers, gingival tissue packs, surgical dressings. Non-eugenol zinc oxide for provisional restoration, root canal sealers, gingival tissue packs and surgical dressing. So based on the bonding mechanism, you have phosphate based, phenolate based, polycarboxylate based and methacrylate based. So classification based on setting reaction as given by Skinner's, based on acid-base reaction, based on light chemical activities, based on polymerization acid-base reaction, then you have a compomer, then resin cement. Then on acid-base reaction, you have zinc phosphate, zinc polycarboxylate, zinc oxide eugenol, silicate cements and GIC. Based on polymerizing materials, you have acrylic polymer, cyanoacrylates, dimethacrylate polymer and polymer ceramic composites. So the other materials are calcium hydroxide, gutta percha and varnishes. So you have silicate cements. It was introduced in 1903 or as anterior filling material. Silicates are attacked by oral fluid and in time degrade. They may not be considered a permanent restoration. The use of silicate cements diminished with the advent of composite resins and development of GICs. So composition, you have powder, you have silica, alumina, fluoride components, calcium salts. In liquid, you have phosphoric acid, water, and buffer salts. So, fluoride flux is also present to permit proper sintering of other ingredients. So, how is the setting reaction? So, powder is mixed with the liquid, and later the powder is attacked by acid liquid containing calcium, aluminium, fluoride, and fluoride ions. So, the metal ions precipitate as phosphate and cement matrix inclusive of fluoride salts. So advantages, it exhibits good aesthetic qualities, it has good anti-carcinogenic properties and analogs to topical upright fluoride solution. Disadvantages is it lacks stability in oral fluids with loss of aesthetic qualities. Rubber dam is essential for successful silicate restoration and it acts as an irritant to pulp. Next comes the zinc phosphate cement. Here again you have composition, powder and liquid. According to Anusavas, you have type 1 and type 2. Type 1 is fine grain for luting and type 2 is medium grain for luting and filling. Then manipulation. So you have to divide the powder in one corner of the glass slab in increments depending upon the product and dispense the correct amount of liquid to the area of the slab away from the powder. We have to add the powder to liquid in portions at 15 second interval for a mixing time of 60 to 120 seconds. Sorry. Mix it over a large area of the slab with a flexible metal spatula. We have to test the consistency of the cement before adding the last portion of the powder. Only part of that portion of powder may be necessary to reach the desired consistency. So the cementing strings about 1 inch above the slab. So next we have the frozen slab technique. Here 50% increased powder liquid ratio is used and mixing is done in a frozen glass slab at 21 degrees Celsius. It is effective when multiple castings are to be cemented. The practical way to increase the working time and reduce the setting time of zinc phosphate is to froze in the glass slab. But the disadvantages is decreases the compressive strength. Next, you have Satan reaction, which is an exothermic reaction, and in this, water is essential or is critical to reaction. Then you have the physical properties, which comprises of compressive strength, tensile strength, modulus of elasticity. Then it has several advantages as well as disadvantages. Then variations in zinc phosphate, you have fluoridated cement, you have copper by silver cement, you have silicophosphate cement. Then you have its composition, advantages and disadvantages. Then comes the zinc polycarboxylate cement. It is the first adhesive material which is developed. The advantage over zinc phosphate is it is compatible with the pulpal tissue and addition to the tooth structure is better. Again you have same powder and liquid and it is manipulated at a powder liquid ratio is 1.5:1. This consistency is creamy when compared with that of the zinc phosphate cement. Here non-absorptive surface such as glass slab or treated paper will keep all the liquid available for the reaction and facilitate spatulation. The strength of the mixed cement is not compromised. So we have the setting reaction and again the properties which comprises of compressive strength, tensile strength, modulus of elasticity, etc. And the advantages and disadvantages: low level of irritation, good addition to the two substances and alloys, good strength. Disadvantages: need for accurate proportion, more critical manipulation and lower compressive strength and greater modulus of elasticity when compared to the zinc phosphate. Then comes the zinc oxide eugenol cement. They are excessively used in dentistry since 1819. It is least irritant of all the dental materials. The poor strength when compared to zinc phosphate and it has sedative effect on the exposed dentin. So again you have powder and liquid ratio and classification: type 1 for temporary cementation, type 2 for long-term cementation, type 3 for temporary filling or thermal insulating base and type 4 for intermediate restoration. Manipulation: temporary cements type 1 and liners is type 4 and long-term zinc oxide eugenol cements is type 2. So zinc oxide eugenol setting reaction, you have zinc dioxide hydrolysis followed by zinc hydroxide eugenol and then followed by zinc eugenol. So advantages is minimal pulp reaction, good sealing properties, and strength is adequate when used as a lining material, and luting of single restoration and retainers with good retention form. Next, you have zinc oxide eugenol modification, where resin reinforced zinc oxide eugenol cements are used, EBA and other chelating agents. Again, you have powder and liquid composition and the physical properties. Then EBA and other chelate cements. It consists of aluminum oxide and other mineral fillers, polymeric reinforcing agents, barium sulfate and zinc oxide powder. In liquid you have ethoxybenzoic acid and eugenol. And same the physical properties, and you have its advantages and disadvantages. Then application as luting agent and cavity basis. Then non-eugenol cement, it is a premixed non-eugenol paste is used for temporary restoration and cavity basis. So the pH of this is same as zinc oxide eugenol. It is not satisfactory material for cementation. So the setting reaction in this is initiated by saliva and water, but it has a better sealing into the cavity walls due to hygroscopic properties. Next you have calcium hydroxide. It has multiple use, though not used as a permanent restorative material. It is a white color odorless powder. The pH, it has an alkaline pH of 12.5. It is classified as astringent in pharmacology. So history, in 1936, Hermann introduced calcium hydroxide to promote healing in many clinical situations. So the introduction of this material was by Kluger and Zander in 1938. So successful pulpal healing using calcium hydroxide is between 1934 and 1941. So the main characteristics are, it is a radiolucent, its pH is 12.5 at 25 degrees Celsius, it has a molecular weight of 74 and a specific gravity of 2.34. On vital dentin, considerably it reduces the permeability of exposed dentin for penetration of bacterial components towards the pulp. This may be due to coagulation of protein in dentinal tubules. Due to secondary dentin formation, it has antibacterial effect. On carious dentin, it has a strong antibacterial effect on the contaminated soft carious dentin. On exposed pulp, low irritation due to coagulative necrosis caused by calcium hydroxide, leading to hard tissue differentiation in the pulp of calcific barrier formation. So different forms of calcium hydroxide are available: dry powder, liquids, non-setting paste. Next you have setting paste, where you have chemically activated calcium hydroxide paste system, where you have a base and catalyst. Then visible light activated calcium hydroxide as a single paste system, and slow setting calcium hydroxide paste. Then vehicles, you have aqueous vehicles such as water, saline and LA solution, viscous vehicles such as glycerin, polyethyl glycol. Then oily vehicles, you have olive oil, fatty acids and eugenol. Then calcium hydroxide, they are used as direct pulp capping agent for indirect pulp capping, apexification, horizontal root fractures, intracanal medicament, prevention and treatment of resorption, root canal sealer, as a liner used in pulpotomy as well as base. So adverse effects are calcification in pulp, internal resorption, ankylosis and increased bitterness of dentin. So summary is, zinc phosphate cement has long served as a universal luting cement. Its advantages include good handling characteristics and proven longevity in the oral cavity when it is used for cementation of well-designed and well-fitting restorations. So the main advantage is they are biocompatible, and the physical and mechanical properties and the handling characteristics are generally better to those of other long-term luting cements. So the properties of zinc polycarboxylate are good compared to those of zinc phosphate, and the outstanding characteristics are their blandness to the pulp and formation of an adhesive bond to the tooth structure. So calcium hydroxide, though it is not a restorative material by itself, but forms as a part of a restoration, its fascinating dentogenic potential have elevated its status and its use in dentistry. Thank you.